Welcome. Today we are going to demonstrate a new handoff method in order to help you provide optimal and appropriate care for your patients. There are several key components to a safe and effective handoff. First, the handoff should always take place in a quiet environment, free of distractions. Not only is it a potential HIPAA violation to discuss patient data in a public place, but a quiet environment allows everyone to focus on what is most important, the patient. The patient handoff should always be face-to-face and never over the telephone or solely through written notes. During sign-outs, the hospital's electronic medical record system should always be used. This ensures that the most up-to-date and accurate information is being passed on. Also, this can help save time during the sign-out because the background information does not need to be repeated if everyone already has a copy in hand. Using these two simple strategies, face-to-face communication and printed lists, can greatly improve the amount of information retained. A recent study demonstrated that after multiple handover cycles, only 2.5% of patient information was retained using a verbal-only method. 85.5% was retained using a verbal method with note-taking, and 99% was retained when a printed handout containing patient information was used. Now that we know how to sign out, it is important to know what to sign out. It is easy to get caught up during a sign-out discussing funny stories, current events, and your latest operative conquests. Some people want to sign out every IV inserted and electrolyte replaced. However, this is not only time-consuming, but also distracting to the pertinent information. We have identified 4 major components that are necessary for a good patient handoff. All 4 of these components should be addressed on every patient, every time. First is background. This includes the patient's name, age, and gender, as well as hospital information like medical record number and room number. It may also be useful to include the admission date, post-operative day, admitting physician, and attending surgeon if different from the admitting physician. An advantage of using the printed patient list is that almost all of the information is already included, thus ensuring accuracy and saving you time during your sign-out. The next major component is assessment. This includes the diagnosis or differential diagnosis and what procedures have been done. Important and relevant comorbidities should also be discussed at this time. When appropriate, a baseline status should be given, especially if it is abnormal but stable. This can include mental status, cardiopulmonary status, relevant vital signs, or physical exam findings. Depending on the patient, it may be worth mentioning any special medications, such as anticoagulants, or special equipment such as wound vac or pulmonary artery catheter. Finally, any complications or unexpected events during the hospital course thus far should be briefly mentioned. Recommendations should follow assessment. Any specific tasks that need to be performed should be noted at this time, as well as alerting the incoming team to pending information, including not only laboratory or study results, but also consultant recommendations. All tasks given should be verbally read back and repeated by the receiver. You may also want to discuss what may go wrong with the patient and what to do about it, including what has worked previously. For instance, a patient may have had problems with low urine output, but has responded well to fluid boluses. Also alert the team to any potential for transfer, discharge, or extubation in order to advance patient care 24/7. You may want to discuss a general plan of care. Finally, code status should be specifically discussed when appropriate. The final key component of our handoff includes exchange. As noted before, this includes verbal readbacks of all to-do tasks. This strategy has been well proven in other industries such as the military and aviation and is now being disseminated throughout the medical field. Other special considerations such as difficult family, psychosocial, cultural situations, or language barriers should be discussed. When appropriate, indicate who should be contacted about specific events. This may include particular family members, the power of attorney, or the on-call surgeon or consultant that is assisting with management. At the completion of the sign-out, take a moment for any questions that arise. Again, each major component should be addressed for every patient, every sign-out, but the particulars will vary based on the situation and severity of the patient. With some practice, this can be done quickly but efficiently. Now, let's take a minute to see what can happen when these strategies are ignored.
Hello? Yeah, babe. I know we have tickets. Yeah. Yeah, I'm going to be there. I'm swamped with work right now. Yeah. Hello? Yeah, can you hold please? Thank you. Hello? Yeah, man, I'm going to make it. I have all these patients I have to hand off, and I'm swamped with work right now. But I'm going to make it. I'm going to be on time. Let me give you a call back, and yeah, all right, love you too. Bye. Okay, you got to check out the tape.
Oh, okay, but let's hurry. I've got to get all this paperwork done.
Alright, just check the list on the computer. If you need to know anything specific, everything should be on there.
Okay. Anything else I need to know?
Nah, but watch out for Big Bird on the 3rd floor.
Big Bird?
This lady, she's arguing with her husband. They're painting her house. She wants yellow, he wants blue, hence Big Bird.
Ah, got it.
And also, Miss Smith in 415, she says she's feeling weird. You might want to check on that. Also, Mr. Stevens in 412, he might have this horrible disease. There's no evidence on the chart for it, but I've got a hunch. You know what? I've got to go.
Okay.
Good?
I guess I am.
Yeah, you got this.
Yeah.
I gotta go. Hey, how'd it go last night?
Oh, hey. It was crazy. Mr. Johnson tanked. We had to intubate him.
Wait, you intubated him?
Yeah, just about an hour ago.
He was DNR. You were not supposed to intubate him. We spoke about this last night.
No, we didn't.
We had a huge family meeting. They all agreed that he was DNR.
I don't know what's gonna happen.
We are in so much trouble.
Do you think this could have been prevented with a better sign-out? Let's take a look at what happens when a structured and organized sign-out process is used.
Hey, I gotta check out with you.
Oh, okay. We'll have to make it quick. I've got a lot of paperwork to do.
It's kind of noisy in here. Why don't we go to another room?
Oh, okay. Good idea.
Here we go. Here's the list. We have 12 patients, but only one is somewhat critical, and I'll talk about her first. Miss Hansen is in the ICU with C. diff. She has CHF, so we're trying to avoid fluid overloading her. She has a central line and an A line in because she is intermittently hypotensive, but she has responded to fluid so far. We have a full set of labs ordered at 8 p.m. If she gets much worse, we've discussed with her family that she might need to go to the OR emergently. Any questions?
What's her code status?
She's a full go.
Okay.
The next patients aren't as critical, but I'll quickly go through each of them anyway, just to give you some background in case something unexpected comes up. First is Mrs. Eager on 6 West. She had her gallbladder out this morning and was admitted for pain control. She has been doing well, and we expect her to go home tomorrow. Also, Mr. Wenzel, he's on 4 East. He was admitted yesterday with partial small bowel obstruction. He has multiple medical problems, including COPD and a recent cardiac stent, so we are going slow and trying to avoid surgery with him. He still has an NG in, but overall, he's stable. Next is Mr. Johnson on 4 East. He had a colectomy for cancer 2 weeks ago, and he was intubated in ICU. He was in the ICU up until 2 days ago. His path came back stage 4, and we had a family meeting today, making him DNR, no intubation. He's doing pretty well on the floor though, so I don't expect a problem.
Okay, so I'll keep an eye out on those labs from Ms. Hansen, and regardless, I'll probably check on her tonight.
Okay. Do you have any other questions?
I don't think so. No.
All right. Well, it sounds like you're ready.
All right. Well, thanks. Have fun at the show tonight.
All right. See you. Gotta go.
All right. Bye.
Hey, so how'd it go last night?
Oh, hey. Geez, it was crazy. Mr. Johnson tanked. We almost intubated him, but thank goodness you told me about that DNR.
Yeah, I just spoke with his family, and they were adamant about DNR.
Crisis averted, right? Thanks to the Bear Handoff.